Welcome to the Society of Hospital Medicine's Education Consult Series, brought to you by the SHM Academic Committee. This series is dedicated to providing hospitalists with practical, easy-to-use teaching techniques, tips, and resources from academic clinician educators.
Hi, Lonika. We're here today to talk about virtual teaching strategies. And so we're all getting used to teaching in a virtual setting. And there's a lot of benefits to using virtual platforms to teach our learners in the health professions. But there's also certain risks. And I think one of the biggest risks that I see is lack of engagement from our learners. You might see on the screen that one learner is not paying attention or checking their phone. And I find it's often hard to engage in a meaningful way with the learners who may not be participating. And so I'm hoping that you and I can put together 3 key principles for effective teaching in the virtual setting. And do you want to kick us off?
I love the idea, Dan. And I totally love the first principle, which is limit the cognitive load. So there is a larger theory behind it, but what I use for clinical teaching is allowing the learners and myself to focus our attention on 2 or 3 key principles of the care of what they're learning about. So as an example, if we have a patient who just got admitted with a myocardial infarction, instead of learning everything that we need to learn about coronary artery disease, we focus our attention on taking a history from a patient presenting with atypical chest pain.
I love that idea. So what I'm hearing from you is being really narrow and focused in the content that you intend to cover. I think this is really important for virtual teaching, and especially in short spurts of teaching. You can't really cover everything. You really need to focus your content area. So that's a great first principle. I think a second principle is employing active learning strategies in your teaching. And what do I mean by that? These are really techniques that are used to engage with your audience. And so using questions is really the big key here. And what I think is important here is to try to move beyond what questions towards how and why. And the reason for that is what questions are often hard to answer if you're a learner, especially using virtual platforms, because if you don't immediately know the right answer, you may not want to speak up. So how and why questions allow the learners to actually reason through a process and think out loud. Another technique is case-based collaborative learning, where the learners are actually working together through a problem or a clinical question or a clinical case. And in that way, they're actually collaborating in their learning. What I think is really important here is that try to think about yourself as an educator, as a facilitator of learning rather than a teacher feeding information to your learners.
I really like what you said there, Dan, and it helps the teacher to stop talking and allow learning to happen around them and to be facilitators, which I think is a skill that I could definitely use. The third principle that I wanted to talk about today was keeping it relevant. So an example in clinical learning might be when you have a patient that's admitted to the hospital and you're caring for them, talk about that patient's care and how that's furthering the learner's education. This really allows for the learners to remember from those crucial patient-provider interactions and helps that information stick in their brains a little more.
Awesome. So I'm hearing 3 key principles. Limit cognitive load by keeping the content area narrow and focused, use active learning techniques such as using questions, and keep the content area relevant by founding it in clinical care of a patient they're actually caring for. So why don't we see these 3 key principles used in practice through a pre-recorded video that we captured with permission from our learners.
Hi, everyone. It was great meeting you all earlier this morning. I am sorry that we didn't have a lot of time to discuss on rounds, and I'm glad we have about an hour time here. At the beginning of this week, I'd asked all of you what topics you'd like us to cover during our rounds or during our afternoon didactics, and I got a list of fantastic topics from each one of you. Unfortunately, we won't have a lot of time today to go over all of them, but my hope is that we get to talk about each of them in bite-sized chunks over the next couple of weeks that we are together. So in this hour, I want to focus on 2 small topics. The reason that I want to focus on these are because number one, These are really relevant to the care of the patients that we're currently taking care of. And number two, these topics have come up quite frequently in our past weeks together. So the first topic is anticoagulation, and I want to focus on discharge considerations for patients who have been um, started on anticoagulants. So we have 3 patients today, and I want us to have that discussion on what we're going to do for them when they get ready for discharge in the next couple of days. So Carrie, before this call, I had asked you to think about Mrs. Smith in room 306, who's been admitted for a blood clot. Would you mind sharing with the group a short summary statement on what she's presenting with?
Yes. Mrs. Smith is a 58-year-old woman with a history of breast cancer, status post chemotherapy and radiation 5 years ago, currently in remission, who presented with an acute right lower extremity DVT.
Great, and it sounds like she's doing much better on the anticoagulant we've started.
She is.
So Carrie, can you tell me what are some of the different types of anticoagulants that we could have started her on and which one we actually selected?
So there's some oral medications. There's, I think, kind of the traditional one or the older one is warfarin or Coumadin. There's some newer ones, the DOACs, and things such as I think apixaban, rivaroxaban, and then there's an injectable, Lovenox. I think there's some other injectables too, but I know that that's the one I've seen used on this service. And then some patients have to get the continuous IV with a heparin drip.
Great. Does anybody want to add anything to what Carrie shared with us? That sounded like a pretty good list. Let's move on now. Maybe Sarah and anybody, feel free to jump in to help any of you, please. Which anticoagulants are specifically useful for patients who have a history of cancer?
Well, I know that there's some stuff where patients who've had cancer will be on like prophylactic dosing with Lovenox. So when they first get diagnosed with certain cancers, that they'll use prophylactic dosing of Lovenox. And then I can't remember which one, but I think there's also some studies about using some of the DOAC medicines that Carrie had mentioned for clots and certain ones of those, especially the apixaban, I think.
Great. And going back to our patient, Ms. Smith, what do you all think about the choice of anticoagulants that we made? Dan, what are your thoughts?
So I believe that we put her on apixaban, which I think is a good choice for her. It's easy to take. There's not a lot of monitoring that has to go on, so she doesn't have to follow up in the clinic. And she has really good kidney function, which is the big thing that we worry about with DOACs. So I think that that's a really good choice for her, even given her history of breast cancer.
Great. So now looking into the future as far as her discharge is concerned, what considerations do we need to keep at the back of our mind when we do end up discharging her from the hospital?
I always get called by pharmacy about cost when I write prescriptions. That sometimes, especially the DOACs, can be expensive.
That's a great point, Jen. So what helps you with answering that question?
I try to ask the pharmacist ahead of time which one might be cheaper based on her insurance. And then what alternatives she's willing to do if the DOACs don't work for her. They're too expensive.
I think the other thing is just making sure that she has really close follow-up and understands, maybe when to come back to the hospital if she has signs of bleeding or bruising or dizziness or lightheadedness, would be concerning signs for maybe bleeding, or dark stools tend to be a common cause. But just also making sure that she's being followed up for her clot with hematology.
Any other considerations? Those are fantastic points.
Dr. Sood, I can't remember with the DOACs, like the apixaban, does she need to come and have her blood checked, the INR?
Yeah, that's a great point. So what do you all think? What kind of parameters do we need to follow up if we're discharging her on apixaban?
I think like Dan said, it's more the kidney function that we need to
Oh,
keep an
okay.
eye on. And
Now,
the-
luckily, we don't have to monitor the apixaban. There's no INR checks. Really just monitor for signs of bleeding. And then she should have her kidney function monitored periodically on that. She's got, what probably a provoked clot given her cancer history. So hopefully shouldn't need lifelong anticoagulation, but would need to have that followed throughout the duration of her therapy.
Great, thank
Oh,
you.
good. She was really worried about that.
Great, thank you. So Dan, I'm interested to know what educational strategies and key principles you saw in that video.
Thanks, Lonika. So I saw some really great teaching techniques employed during that brief teaching session. And if we're going to found them in the 3 key principles that we talked about in the beginning, first, the content area was focused. It was really focused on the types of direct oral anticoagulants that can be used for this patient. And what I love about it is it's pretty narrow, that you can actually do a pretty deep dive in a short amount of time. You're not talking about all the indications for every single DOAC, their mechanisms of action, what evidence is in the literature to support apixaban versus rivaroxaban versus warfarin. It's really just focused on the types of DOACs you can use for the specific problem. The second thing I saw done really well was the active learning strategies. And so I saw that you asked for a summary of the case, and what that did was provide some context and to frame the discussion and bring the learners back in time to when they were caring for a patient. And then I saw you ask a lot of really great questions. You started with a what question around what types of direct oral anticoagulants can be used. But I saw how you were able to move in the one-room schoolhouse. So asking the medical student for a summary and then a what type question, but then asking a higher order question to the 3rd-year resident to get them to think out loud through how they were thinking about what direct oral anticoagulant to use for this patient. And so that's a way of being able to engage all the learners who are in the same session, but might have a very different level of understanding of the not only patient's problem, but what the specific clinical question you have for them. And finally, relevant to the clinical care. So because you founded it on a specific patient you saw in rounds earlier, and it was focused on a clinical question that you discussed, this actually makes the content stickier. So the next time they see a patient with this problem, they're going to remember your teaching session and remember the discussion between apixaban versus rivaroxaban versus warfarin. So I saw really 3 great foundations of active learning and engaging your audience of virtual teaching in that teaching session.
Thanks, Dan. And I'm glad that you were able to see all of those strategies, because it was a blast working with the students. And I hope you also saw my resolve to not to jump in and try to solve all the problems that the students were bringing up and our learners were bringing up. We have a very smart group of trainees there. To our audience, thank you for watching this video. We hope you will take a moment to complete the evaluation form. And after you do that, we have a few more resources that we would love to share with you.